So, good morning. And yes, this one is on COVID-19, sort of. I know that COVID-19 has become such a major political issue, and I try as hard as I can to stay out of politics. So it's not easy sometimes to stay out of politics when you're dealing with an issue that's wrecking the economy. Today, it's really, we're going to be talking about statin therapy and COVID-19. The reality is this is more of a discussion about statins than it is COVID-19. And here's why. You will hear, I'm going to cover an article that actually talks about using statins and makes some assumptions that statins would actually help for dealing with the cytokine storm for COVID-19. Now, really? Let me, if I say it once, I'm going to probably say it 1,000 times. There has been no research in this area. I am not recommending statin therapy for COVID-19. Here's the reason that I'm covering this article. It gets back to this issue of pleiotropic mechanisms. Pleiotropic, what the heck is that? That's a $2 word for a 50-cent concept. The concept is, you know what? Some things have more than one mechanism. Metformin, for example. Metformin, the major mechanism appears to be the fact that it decreases the liver's, what we call gluconeogenesis, glucose making, new genesis making. So metformin has more than one mechanism. One of them is to decrease the liver's ability and activity of making new glucose and dumping it into the bloodstream. Metformin also makes significant changes in the gut biome, from the gut biome that you tend to see with someone with diabetes or prediabetes back to the gut biome that you tend to see with someone who doesn't have that. There are plenty of other examples in medicine about what we call pleo, meaning many, trophic, going towards mechanisms. So statins are the same thing. I actually do recommend and use statins, but not at all like you tend to see in most of the rest of the medical world, like 99.9% of docs. They tend to use statins for treatment of cholesterol, and they think that high LDL is bad, the quote LDL or quote bad cholesterol. But then most of the viewers on this channel are smart enough and informed enough to know that there's a major debate about that. I think it's Nir Ali and several other internet docs make the case that the more LDL, the better. And there are guys like somebody help fact check me or help remind me, Dave, I think it's Dave somebody that talks about lean mass hyperresponders. A lot of people talking about little to no problems associated with LDL. And in fact, in my practice, as you might guess, I see a lot of people that are lean mass hyperresponders, people that go on a keto diet or a low carb diet, and their LDL actually increases. And for them, that's probably not a bad thing. Now, there are other people who look at the other side of this issue. Joe Riley, one of our supporters and a subscriber, a viewer, he's actually participated in a couple of interviews for the channel. We were talking about that, or we were chatting about that on the chat before the video started. Joe Riley he's shared that he's got not only FH, familial hypercholesterolemia, but world-class levels of Lp(a), and again, world-class levels in both. Joe has looked at the science and said, look, for people like me, it probably is better to have significantly lower LDL levels, as in the 30s and 20s. And again, he shared that story with the crowd. So There's clearly arguments about whether or not statins and their effect on lowering LDL is that attractive. The major argument I would say about statins and lowering LDL is this: half the people that have a heart attack or stroke have a normal or lower LDL. So that tells you something right there about the 99.9% of doctors who use statins for LDL. For the rest of this discussion, I'll wait until we get through the introduction and then get to the program after Carl does the water ball to get us into the main program. Upcoming topics we'll have for this: antibody cocktails for treating the coronavirus. Coronavirus has been around long enough. There are companies that do this. They've harvested T cells and B cells from coronavirus patients, started to grow those cells on a mass basis in order to start getting antibodies for that. As we start getting deeper into our schedule, we plan to cover that. As you know, we've got a lot of previous topics in this area. During a 2-month period when the world in the US was getting used to what the heck happened with this pandemic, all of this coronavirus, COVID-19, we went into a period of daily COVID-19 activities. And some of the more popular ones have been, the events have been on supplements versus lifestyle in COVID-19. And yes, a lot of the very same lifestyle issues that help you prevent COVID-19 if and when you get your coronavirus infection are the same lifestyle things that help you prevent heart attack and stroke. So these topics were very much in line with this channel. Other things that have been popular in the COVID section had to do with supplements. Again, some similarities with supplements like vitamin D3, big supplement for this area. In terms of the fear factor always jumps in. That topic and that coverage of, what was it? D63G or something, the mutation that was documented by Los Alamos labs. A lot of people were very interested in that. So we've got a lot of stuff about that in our content. As we've mentioned, we're going from that 2 months of daily YouTube lives on the coronavirus to back more towards our standard pre-coronavirus YouTube live schedule, where we'll be going Wednesdays at 11 o'clock. Those of you who have been patient with us as we've gone through our challenges with email systems, you know, when we originally set up our email systems and our subscriptions, we said, look, we don't plan on bothering you more than once a week. And then when the daily lives happened, we found that people were asking us, they were using those emails as an alert that, you know, we're getting ready to have a live session. A lot of people liked it. It was very popular, but again, that put us right in contrast with that original commitment to keep it to once per week. We know there's a way to segment it. We knew it before, but we had not started yet. So that was our first segmentation. And from what we can tell right now, we do think that if you've requested no more than once a week, that you're getting it no more than once a week in terms of our email. If you've requested it every time we get a YouTube live, when we're able to get it out, sometimes SendGrid has glitches. But we think that you're getting the YouTube announcement email the day that it's coming out. If that's not the case, if you would just call or email us at myhealth@prevmedheartrisk.com. And the number is 859-721-1414. That's 859-721-1414. Now, Carl, we may have switched those numbers around. If we have, I'm going to ask you to let me know and we can give a new and better number. Other updates that we've covered in the COVID-19 space, new tests that are becoming available, problems with the Abbott rapid test being used in urgent care clinics, challenges and discussions about coronavirus transmission rates. In order to continue to provide the work that we do to be more budget friendly, we're doing several things. We've set up a program where you can actually just register and hit my schedule on Calendly. We've got people that will do that, go in and get a 15-minute time slot with me, and it doesn't matter if it's a prevention issue. People are using it for follow-up. Other people are just using it for an urgent care visit when they can't figure out how to get it done with their doc. The other thing that we're doing is webinars. Those have been very, very popular. A lot of people have questions about whether or not they have blood sugar problems. The underlying issue for most of us that are going into the risk decades are 50s, 60s, 70s, those risk decades for heart attack and stroke. Are we developing plaque, which creates the risk? What creates that plaque? Blood sugar problems, metabolism problems, and we're developing much more affordable ways. You go to, the California Health Institute, you spend a week at the Four Seasons, and about $10,000 later, a few stress tests later, a lot of time with internists and health coaches, and some great spa food, a great experience. But again, $10,000, $20,000 later, you still don't get the stuff that you get with us. And we're down now to some less than $200 price frames on some of the critical information that we're providing. Some of that critical information has to do with supplements. Supplements is a huge topic. When I see patients and we start going down that supplements hole, we can spend hours talking about individual supplements. So again, trying to get that supplement information out there in an affordable way, the webinars have become a great, very cost-effective way for folks to get that information. So Michelle has been working. We've developed a supplements webinar. Feel free to take a look at it. One of the other ways that we're getting, again, more cost-effective for delivering our services is monthly subscription plans. A couple of people we just rolled this out, less than a week ago, and a couple of people are already saying, this is very interesting. And as we predicted, a couple of people are saying, well, could you do something between the silver and the gold? And the reality is that, yes, we can, but you need to call and talk with us and maybe help us as we develop this, the most attractive offering for serving patients, serving you guys. Just a quick update on the book. There's a fellow that called me. I'm not going to use his name right now because he hasn't given me permission. We haven't talked about it, but he's looking to write a book and was looking for me to participate as a co-author in terms of looking at methods of prevention. This fellow has owned and run book writing companies, and he started talking with me, and I haven't talked with Todd yet, but plan to, about putting this, shopping this book with one of the bigger houses. Right now, we're not doing with a big house. We're planning on this just being a small, simple, self-published type of activity. The bottom line on the book, and again, maybe 2 months from now, plan for it to come out, is that the greatest way to, one of the greatest ways to miss a heart attack is what almost everybody's doing. They say, you know what, hey doc, my uncle had a heart attack, could we get a stress test? And then you go down the stress test, the Framingham, the stress test, the cath lab, all of the wrong places. And you end up either A, having negative results and thinking you're okay and dying like so many people do, or B, getting a whole bunch of procedures thinking that you're now cured of a problem and you missed a bullet and you didn't. So lot of challenges. We also present, it's not all negative about what's going on wrong. It's also suggesting and making some very clear instructions and helpful science behind what are the better ways of finding out if you have heart attack and stroke risk, finding out if you have plaque and what to do about it. And the simple version is CIMT, calcium score, and CT angiogram. Those are all three ways of dealing with this that are much better than getting a stress test and trusting your life to that procedure. So we'll get back to statins and COVID-19 right after Carl gives us the water ball. Carl, I forgot that I didn't have it on presentation mode, so I think everybody was looking through a little keyhole at my images a few minutes ago. Sorry about that. Let me start this with another repeat of that disclaimer. Yes, we're talking about an article that was in the European Heart Journal, Cardiovascular Pharmacotherapy, Statin Therapy and COVID-19 Infection, and I am not saying go out and start taking statins for coronavirus. I'm not saying that. Please let me repeat again. That's not what I'm saying. The reason I'm covering this, though, is, again, as you'll see, statins have an interesting effect regarding cardiovascular inflammation. And that's the reason that I tend to use statins anyway, not very often to lower LDL. I do have a lot of patients with FH, and for some of those patients, LDL does need to be lowered. But that's not what I usually use it for, and that's not what we're talking about here today. In this paper, some quotes from this paper in the European Heart Journal. In this paper, we support the rationale for the use of statins, a class of drugs with widespread availability and an optimal tolerability profile, as an add-on treatment for COVID-19 patients on the basis of their known immunomodulatory properties. Gosh, you know, another $5 word for a 50-cent thing. Easy for me to say, huh? Immunomodulatory simply means it's anti-inflammatory. It decreases inflammation in the cardiovascular system. Besides their lipid-lowering activity, statins exert pleiotropic, again with that big word, pleiotropic effects on inflammation and oxidative stress, contributing to their beneficial impact on cardiovascular diseases. Statins have proven to be beneficial for different autoimmune inflammatory conditions. Although observational studies have reported improved outcomes in patients with community-acquired pneumonia or sepsis receiving statins, most RCTs, randomized clinical trials, the ultimate in research. Most RCTs on inpatient statin treatment in sepsis or ventilator-associated pneumonia failed to demonstrate a beneficial effect. And if you go out, you misquote me, you say, look, Brewer's saying use statins for COVID-19. I mean, everybody's going to react and say the same thing. The randomized clinical trials have said they're just not really showing that much of an effect. And that's what these guys, to their credit, are acknowledging as well. Now, on the other hand, statin therapy appears promising on the context of viral infections. As an example, they mention avian influenza viruses inducing an intense host response characterized by a cytokine storm. Anybody heard that term recently in relation to COVID-19? Cytokine storm? Which can sometimes lead to ARDS. And again, we're hearing about ARDS from the beginning. ARDS, what's that? It's an acronym for Acute Respiratory Distress Syndrome. Some people use Adult Respiratory Distress Syndrome, but for the most part, this is the term that the word that you should use would be Acute Respiratory Distress Syndrome. Similar to an avian influenza virus, beta coronaviruses cause severe respiratory illnesses by triggering an intense pro-inflammatory host response. The term pro on here is It's not necessary. It's an inflammatory host response. Some immunomodulatory therapies have indeed proven beneficial in patients with SARS, MERS, and even COVID-19. Statins also interfere with ACE2 signaling. Statins, as well as ARBs, are known to experimentally upregulate ACE2 via epigenetic modifications. Let me go back and rephrase that. When we see a patient, one of the things we do, we will be fairly liberal in terms of interpreting their blood pressure. For example, if I see somebody with a recurrent 120 over 85 or 125 over 80, I will want to use that as a reason to justify a very low dose ACE inhibitor. Why is that? Because the combination of ACE inhibitor, even low dose, and statin, even low dose, is not additive in terms of cardiovascular inflammation. It's multiplicative. It's not. It's the sort of thing where 2 and 3 doesn't make 5; it makes 6. So the combination, and that's what they're talking about here. Again, using maybe too many big words. So that's the short story on thinking about statins and COVID-19. So next we'll go to the Q&A section. Carl, you want to give us the intro to that? So thank you very much. And is it Iker Boisel? Sorry, Ilker. Started us right off and nailed the topic. Anti-inflammatory effect of statins against COVID. You're exactly right. John Tucho, good to hear from you, John. I don't mind getting emails from important sites like yours. Well, thank you very much. I appreciate that, John. Dave Murphy has started us off with a super chat. Carl puts this up in the right-hand corner so you can take a look. Basically, if you'd like to do one, you go to the comment section, and then right next to it, there's a super chat button potential. Thank you, Dave. I appreciate it. I really do. What that does, I mean, it may not seem like much, but it really does help, both on an emotional basis and an actual financial basis. As you may have noticed, most of our support staff, Carl, Cindy, Lori, live and work in the Philippines, and $5 in the Philippines is much more significant than $5 here. It is a great way to expand and scale our ability to get that message out. Dave Murphy, looking forward to the book. Please let us know as soon as it's available and when we can order it. I will do that, Dave. I think I started down that bunny trail on the book and forgot to tell you the most recent news. The fellow that's talking with me about doing his own book and asking me to co-author asked me yesterday, he said, there are a lot of big houses that may be interested in the book that you and Todd are working on. Again, Todd doesn't know that yet. And so we may agree to go ahead and shop that with one of the big houses. If we do, one of the problems with working with those guys is they tend to have a schedule of their own. And this is information that we'd like to go ahead. We feel like we've delayed it long enough. We'd like to get it out there. So that's going to be one of the decision points. But thank you for asking, Dave, and we certainly will get that information out as soon as possible. This looks like a message from Lori. We've asked Lori to start making folks aware. Hi, I'm Lori. I'm the nurse educator with PrevMed Heart Center. I'd love to hear about your health goals or concerns and answer some questions that you may have about our services. Now, Lori's number is 859-757-2324. That's 859-757-2324. And thank you very much, Lori. Tim, Tunnel. I've been following your site quite regularly. Enjoy all the latest info from you. Keep up the good work, Doc. From Malaysia. Well, thank you very much, Tim. I think you may be the first commenter from Malaysia. Thank you so much for your interest. Thanks for the comment, and thanks especially for telling us where you're from. We've had folks from, actually we've got patients as well from the Middle East, from Australia, from Brazil, from, oh gosh, another word finding problem. What's the name of the country? New Zealand, England, you name it, France. We've got folks from all over the world. So thank you for joining us, Tim. Energy, $8 super chat. Energy, I don't think I recognize the label or the ID. Thank you so much. Okay, Joseph Page. Seems almost everybody who contracts the virus is temporary asymptomatic for at least 3 days before they show symptoms, and maybe much longer. I assume they're contagious to others during this time period. Well, here's the issue. It's a great topic, Joseph. And for those of you who missed the old shaky paper days, I'm going to go back. I mean, I could probably find some of those images, but I'd rather just go. It would take longer than just drawing it out. So, yeah, there you go. So if this is the time period that you get infected, day 0, you get up to about, you've got a 3 to 5 day period where, and this is for almost any virus, most infectious processes. You get a 3 to 5 day period where there's, in some it's as few as 2 days, where you get growth of the virus and you start getting into a geometric growth pattern. It's not until some time period here that you're actually infectious to others, just because there's so little virus in the blood that you're shedding at that point. And then at this point, pardon me, I have to go backwards in terms of what I'm seeing. At this point, you start developing IgA, IgM, IgG. IgM tends to start at about day 14. You're almost tend to be infectious through the IgM development phase. IG means immunoglobulin. It's the antibodies. Usually, for most viruses, it's about day 21 that you really start getting effective IgG, and your infectiousness, depending on the virus, depending on the individual, as you start developing an effective antibody and immune response, your infectiousness to others decreases as well. So I hope the guys that missed the old shaky paper days gave you a thrill again. And Joseph Page, I really appreciate you bringing up that concept. It's a concept that we all need to be aware of. As you may know, I'm doing a lot of work recently with helping large employers get their employees back to work safely. And those concepts are very, very important. You know, those concepts also have to do with the challenges in terms of getting an antibody test that actually works the way we need it to work on a functional basis. Because as you can see here, you know, the first couple of weeks, you can have you'll have a negative antibody test, but you've still got the virus cooking in there and growing. And then I'm not going to go down that bunny trail in terms of talking about negative antibody tests later on, except to say one thing: in a place where there's a low probability of infections, let's say 2 to 5%, and it's not even 2% right now in the U.S. A great test at sensitivity and specificity 95%, you will typically have for people that test positive, you'll typically have half of those being a false positive test. That is another, excuse me, that's another major concern in terms of developing an antibody test that we can use, because it will boil down to this. Well, if I've got a positive antibody test, I'm immune, right? A lot of people still assume that. And you got to go back to the last statement I made. Even with a good 95% sensitivity specificity, half of the positive tests are going to be false positive in a low prevalence, a low rate of infection area. Now, we're not saying low infection transmission rate, we're saying low rate of people, number of people that have it. So when you interpret it that way and you think about that, you think, I've got a positive antibody test, I'm good to go, I'm safe. Well, either that or you've got a 50% probability of that being a false positive test. That's where the challenges come in with just saying, we're going to get an antibody test and everybody that's positive is good to go. Joe Riley, please, all 63 of you hit thumbs up. Thank you so much, Joe. Thank you for the reminder. And Joe was also the fellow, he called me, I think it was one weekend, or texted me and had this brainchild about saying, you know, Doc, you're pretty good at verbally pointing out the fact that more of us are dying on a routine basis from heart attack or stroke than are dying even in the, quote, height of the COVID-19 epidemic. And you see that before. So that trailer before the show was Joe's brainchild. Thank you, Joe. Now, you get into some technical questions about, oh, wait a minute. Where did you get the heart attack and stroke death numbers? We have to get those from rates the previous year, which is the most recent time they were posted, and then multiply them out. But wait a minute, aren't you double counting? And aren't a lot of people that would have had heart attack and stroke actually being counted as dying from COVID-19? Yes, and actually a lot of those people dying from COVID-19 are people that would have died from heart attack and stroke. But yes, all of those criticisms and concerns are true. They don't change the fact that in the height of the COVID-19 pandemic, more of us are dying from heart attack, more of us are being permanently disabled from stroke than from COVID-19. No question about that. So thank you again, Joe, for your support of the channel. Dave Murphy, 98% and 53 BPM. And for those of you who don't know what that means, that's based on another of Joe Riley's ideas. Joe was saying, Doc, you really should cover pulse oximetry. And I did cover it, and I did get my own little pulse oximeter. And the point behind the pulse oximeter is this. Most of us are going to continue to have good numbers, but this virus is sneaky and unique in being sneaky. It took me 2 weeks to figure this darn thing out, by the way, because I was hard-headed and didn't want to read the instructions. This virus is sneaky. People will have oxygen saturation rates that are way low. 70s, 60s, you know, starting to get towards ventilator level. But they're sitting there working on their cell phone. Now, I had a comment from a viewer that said, Brewer, you said saturation levels in the 40%, that's not compatible with life, and just a whole bunch of misquotes. The bottom line is this. Yes, COVID-19 is sneaky in terms of hypoxia. So that's the purpose of these things. Now, a lot of people will say, no, that's crazy. Don't try to self-treat with that. You know, pay your money, take your legs, decide whether or not you, what you do in terms of life is your decision. Chuck K, by the way, I'm hooked on these daily chats. I know it's a lot of work, but it really is appreciated. Chuck, I do appreciate that. And I think, Chuck, you might be one of the guys that asked about the subscriptions. if you were, please call us at 859, what is it, 721-1414, or email at myhealth@prevmedheartrisk.com. And I think you were one of them that wanted to adjust it. I'd love to hear what your thoughts are about adjusting it. You may not be the only one. Now, Chuck, here's the thing. I don't really mind. I love doing the events, the daily events. And obviously there are a lot of people that do like them, like yourself. There were three major issues that were going on. The first one is, as you know, there are just the troll community, the hater community, the political focus that's saying anybody talking about COVID-19 on YouTube needs to be hounded, pounded, and done away with. You know, that creates a lot of comments that we just have to detox off of the channel. That's one issue. I mean, and that was one of the bigger issues in terms of slowing back down. The second one was related to that, and that was, yes, there's a lot of science still happening, but so much political focus. I'm not sure why I'm sorry about that. So much political focus that again, it's become more of a political item than a science item. We do plan to continue to cover COVID-19 related issues, just like we're doing today, but just not on a daily basis. The other two issues were the fact that, again, I'm spending a boatload of time, number one, improving our channel infrastructure and helping us get that message out there to the hundreds of millions of people that that have building risk for heart attack and stroke and don't know it, and COVID-19. The work that we're doing with the employers, a lot of this became a time issue. It takes about 2 hours of my time, plus 2 to 4 hours of Carl's time, Lori's time, all of which we're taking away from other activities. So we will continue to do YouTube Live, but not on the daily schedule. Thanks for the comment. Energy, I'm a loyal silent viewer, evidently, and thank you so much, Energy. And thank you for breaking out of that silence. Erland FR, good morning, Dr. B. Would like your thoughts on my next text, not related to statins or COVID-19, but related to pre-diabetes. Okay. Read an NIH report on pterostilbene. The authors concluded that the effects of pterostilbene were comparable to the experimental effects of 500 milligrams per kilogram of oral metformin in the STZ-induced DM model. The STZ is sulfamethoxaz. It's one of the sulfa drugs that we can use, experimenters use in the lab for diabetes. You inject mice with this, and it wipes out their beta cells in their pancreas. So you get a model for diabetes. So I'm not familiar with pterostilbene, Erland. That's an interesting question, and thank you for raising it, but I don't think I'm going to be able to give you a lot of opinion either way. Joe Riley, 98%. Chuck K, I just signed up for silver today. Thank you, Chuck. Lori is great. Yes, she is. We've been working with Lori over the past few days, and with Cindy, short for Cinderella. But what is, she introduces herself by saying, my name is Cinderella. Anyhow, not the same Cinderella that you've heard of. Cindy is coming on to help us get this message out. So somebody like Lori, with what she's doing, is a major component of those processes. So thank you so much, Chuck. Erland FR, your morning chats are great. I wonder why every day there is always one thumbs down. Oh, I wonder why every day there's always one thumbs down. It could be somebody just doesn't like me. I think more likely, I don't think I'm well known enough for somebody to come on every day and do that. But I think it's the the politically motivated stuff. Thank you, Erlen. Maybe they should, maybe, yes. Well, here's the problem. I don't think they're watching. I think they're scouting out channels that talk about it and going in, doing their dislike and moving on. But here's one of the things, it's an interesting thing, Erlen. Here's one of the things that the guys that hit the dislikes evidently don't know. A dislike makes the YouTube algorithm push your content as much as a like. Now, why would they do that? Because they're reading for conflict. Conflict draws eyeballs. Conflict creates interest. So I don't feel so bad about the guys that give us the thumbs down. And in fact, if you'd like to do that, more power to you. Barbara McIntosh. Not sure what those smiley faces mean, but I can't really see them well enough. It looks like there's a bunch of different kinds. 147 degrees west. For those of you who don't know where that is, that picture of that bear may be a clue. That's in Alaska. I usually have to catch the replay. Well, I can understand that. 11 o'clock now is probably what, 7 a.m. your time? But thanks for the comment. Chuck K, I'd like to see a membership like silver, but includes gold level 1/4 annually. I don't think I need a quarterly visit in labs, at least not yet. Actually, Chuck, if you would ask Lori to give you my cell phone number, I'd love to talk with you a little bit more to help understand that. For the reasons that I mentioned before, we want to talk to people that are interested in this and thinking about it to figure out what we can provide that might be the most helpful for you. Now, as we develop a subscription, as you know, I mean, the way our subscriptions work, they set up the previous 2 or 3 months, provide information, provide a lot of content-related services, but they also build up enough equity to pay for things like a one-on-one hour event or half-hour event kind of thing. So that's part of what they're doing. Now, I will say this. I think you're right, Chuck. I think that the assumption that we're starting with at this point is for gold to have like a 3-month one-on-one. And I'm open to looking at a 1-year one-on-one. At Rob, following since 2017, think of the knowledge I've received and have gained through these videos. I can't thank you enough for all you've done for me. Well, Rob, thank you very much. I do appreciate that. And I couldn't enjoy anything more for my retirement. Yes, Janice and I don't get out and play golf enough. We're not the greatest golfers. And starting March 3rd of this year, we don't travel much at all anymore. We don't go out to eat. Just starting a few weeks ago, April 23rd, her birthday, we did start doing takeout. So we're having a blast. This is my third retirement, and I could not think of anything I'd rather do than help people improve their lifestyle and get what they need to live a long, healthy life. Wait a minute. Okay. So 147 degrees west, pterostilbene is found in blueberries and dark blueberries like blackberries. Well, I love blueberries, I love blackberries, and I recommend both of them for health purposes. So that is very interesting. Thank you for providing that information. And 147 degrees west, by the way, is a great contributor in terms of some of the science. In fact, it was 147 degrees west that taught me about a little bit, brought up the whole topic of the glycocalyx. And if that's not ringing any bells, it should, especially if you're a geek about what actually causes heart attack and stroke. The glycocalyx is the link does appear to be the link between glucose metabolism problems and heart attack and stroke. So I won't go any deeper down that bunny hole, but thank you so much for your contributions. John Tocho, I agree with Chuck. I like the gold, but we'll probably get the silver and then buy a 15-minute consult. That seems about right for me. You know, that's interesting. I've got people that are doing, that have started with the standard programs. And I'm seeing one on Monday, I think, that did exactly that, or something very similar to that. They got started on the standard program and then set up a 15-minute consult a little bit later. So thank you, John. It's a great comment. I appreciate you sharing on that. And we are at the end of our comments. We've had some great comments today. I really appreciate the interest. And it's like one of my patients said the other day, he appreciated what I do. And given what I do, I have to tell you, I cannot appreciate it more when somebody actually takes control, learns what they need to learn, stops depending on their doc to make all of their critical health decisions for their life. Again, I'm sorry that it's got to be that way, buyer beware, but it does, because what doctors do for our health is a tiny drop in the bucket. What we do on a day-by-day, minute by minute, hour by hour, day by day, week by week, decade by decade basis is really what drives our health. Now, doctors can help, especially during some critical times, but you can't supplement, you can't prescribe, you can't medicate, you can't surgerize, you can't procedurize, you can't stent, you can't bypass your way out of a lifestyle issue. And unfortunately, so many of us don't really know the key lifestyle components that are driving our health. Thank you so much.